الاستاذ الدكتور الشناوي، الاستاذ الدكتور صبري جوهر، الاستاذ الكرام انهم دعوني ان انا اكون معاكم النهارده كهذا المؤتمر. و today I will speak about GI products in hemodialysis. This topic is very important as symptoms are common. 80% of patients reporting complaints with increased frequency of upper GI symptoms such as gastritis and gastroparesis, and lower GI symptoms such as divertical disease and the chronic perforation and other rare syndromes such as idiopathic dialysis ascites, nephrogenic ascites. This is a very important paper which have reported gastrointestinal symptoms, which is a comparison between patients undergoing peritoneal dialysis and hemodialysis. As we can see, constipation represents about 38% of the complaints in hemodialysis patients, abdominal pain about 32% of these complaints, reflux about 25%, indigestion about 30%, and diarrhea about 18%, and eating dysfunction reaching about 40% of the cause. When we are speaking about gastrointestinal symptoms rating scale scores, we found that hemodialysis patient groups, usually the score is more than 1, which means that it's highly symptomatic rather than peritoneal dialysis group. Very important to evaluate these upper gastrointestinal symptoms and the effect of different modalities of treatment in patients of chronic kidney disease. As we can see here, as we can see in this one, baseline analysis of GIT symptoms in this paper, we can see that hemodialysis, we have higher incidence of GIT symptoms such as nausea, vomiting, and anorexia, and these symptoms represent about more than 80% of this profile. Okay, and when we can follow up baseline endoscopic findings, we can find that erosive gastritis is the commonest endoscopic finding that can be found in these patients. And when we found that post-treatment comparison of the upper GIT symptoms, pre and post, we found that the highest manifestations with hemodialysis patients, and these manifestations declined markedly after its treatment. When we found effective different therapies on endoscopic findings, we found that the highest abnormalities is present in hemodialysis group, higher than other types of groups, and of course erosive gastritis represents the highest incidence. We found next. We'll speak about dyspepsia. Next. It is non-specific symptoms, represents about 48% of symptoms, mainly in case of GERD syndrome 12%, ulcer 19%, and motility disorder, which is gastroparesis, 17%. There is debate about the prevalence in dialysis patients, if there is difference between it and general population, but peritoneal dialysis have higher incidence of dyspepsia than hemodialysis patients. Next. This is another article which is very important about the evaluation of upper gastrointestinal symptoms and the effect of different modalities of treatment in patients of chronic kidney disease. Next. We found that, next, hemodialysis group represent the higher incidence of dyspepsia rather than other groups. Next. And also we found that here, the hemodialysis group, next, has higher incidence of dyspepsia scoring system. Next. What about peptic ulcer disease? Previously, it was claimed that there is increased incidence, but now in endoscopic studies, there is a debate about if there is no more frequent in dialysis than in non-dialysis patients. Esophagitis represents 13% the least, then gastritis, then 22%, and duodenitis gastritis 60%, biopsy, histology, the most common histology is gastritis 46%, followed by duodenitis 43%. Non-dialysis patients is associated with two major factors, H. pylori and non-steroidals, but these factors has nothing to do in patients with regular hemodialysis. This paper showed that peptic ulcer disease risk in chronic kidney disease, 10-year incidence, ulcer location, and arteriogenic effect of medications. In this disease, we found that CKD patients, and especially on dialysis patients, have higher incidence of peptic ulcer disease rather than normal population. And of course, hemodialysis, also CKD patients, have higher incidence of peptic ulcer rather than other population. Here, when we compare the outpatient and the inpatient, we found that peptic ulcer also is increased incidence regarding the outpatient and inpatient rather than other population. What about prevalence of H. pylori infection in long-term hemodialysis patients? At the start of the disease, there is no difference between H. pylori and other normal, non-renal, with no renal function patients regarding the H. pylori incidence. But the strange is, with start of dialysis after 4 years, there is decline about 30% in the incidence of H. pylori infection. This is claimed due to reduction of HCl secretion due to chronic gastritis. As we can see here, we found that H. pylori is higher in diabetic patients at the start of dialysis regarding other types, original diseases of renal failure, and at the end, usually it is declined. This is a very important meta-analysis review of H. pylori infection and the chronic renal failure patients. These are all the studies which have been done, and these studies have revealed that there is no difference between hemodialysis patients regarding the incidence of H. pylori. I know that some sporadic studies reveal that there is difference, but actually there is no difference in between them. And this is the treatment modality. When we are starting hemodialysis, H. pylori is at a higher level, and with treatment with hemodialysis after the passage of 1 year, usually there is marked reduction in the rate of H. pylori. H. pylori infection in dialysis patients is another meta-analysis. طبعا البيبرز كلها صفصفت على 15 paper. With this paper also believe that there is no difference regarding the H. pylori, except after 4 years of the dialysis duration, there is marked reduction in dialysis, in the incidence of H. pylori after 4 years of dialysis modality. What about other GIT symptoms, such as upper GIT bleeding? There is increased risk of bleeding due to platelet dysfunction secondary to bulimia and the intermittent use of heparin with dialysis. Causes of upper GIT bleeding: peptic ulcer, gastric ulcer represent 37%, renal ulcer 23%, angiodysplasia, which is arteriovascular malformation 13%, more in hemodialysis compared with peritoneal dialysis patients. Aspirin usually these patients must be taken carefully and weigh benefit against risk issues. Esophageal varices from repeated application of central cath, obstruction of cerebral cava may produce esophageal varices, and this of course may be responsible for bleeding. Other factors, that the factors which are normally are responsible for dialysis as other patients, non-renal patients. What about recurrent bleeding? We found that hemodialysis patients have recurrent risk of bleeding about 25%, while non-renal failure patients 11%. This is a very important paper about upper GIT bleeding in patients in chronic hemodialysis. We found that the source of bleeding usually gastritis, ulcer, duodenitis, and gastric ulcer. These are the commonest causes of bleeding from the upper gastrointestinal tract. What about characteristics of non-variceal upper gastrointestinal hemorrhage in patients with chronic kidney disease? We found that they have discussed about the location of the ulcer, the number of the ulcers, and the size of the ulcers, and a scoring system has been done, and other risk factors such as alcohol and smoking, so that we can estimate the risk of rebleeding in these patients. gastrointestinal bleeding in patients treated with hemodialysis, a population-based cohort study, we found that usually the free survival, the upper GIT bleeding free survival period usually is lower, of course, in hemodialysis patients. And here, as we can see, hemodialysis patients are characterized when compared with normal personnel, but by higher incidence of gastric ulcer, duodenal ulcer, and number of gastric peptic ulcer, and number of gastrointestinal ulcer, and number of gastritis, duodenitis with bleeding. So that hemodialysis is a major risk for upper GIT bleeding, especially from gastric ulcer and duodenal ulcer. Risk factors for upper gastrointestinal bleeding among end-stage renal disease patients, we found that the esophageal bleeding is the highest, very high risk in another paper, represent about 7% of the causes, while gastritis with bleeding represents about 6.9 risk of the causes, and duodenal ulcer represents about 4.8 risk of the patient. This was found in another study. What about gastroparesis? Which one of the disorders that may occur in cases of renal failure patients? Motility disorders, delay empty, anorexia, nausea, and vomiting. When they are present, usually we may think about initiation of dialysis, and these symptoms may improve. Gastroparesis unresponsive to dialysis, we should think about autonomic neuropathy, particularly in diabetic patients. Occult gastroparesis mustn't be missed as a cause of malnutrition in these patients. When we want to evaluate the gastric emptying time, this is through radionuclide gastric emptying scans. And these patients usually respond well to prokaryotic drugs. What about gastric emptying study by scintigraphy in patients with chronic renal failure? We found in these patients that the patients who are on conservative therapy have higher risk, followed by hemodialysis patients and followed by the control group. Dyspepsia and gastric emptying in end-stage renal disease on hemodialysis, we found that the gastric emptying time is higher in the dyspeptic patient rather than non-dyspeptic patients. Also, the same regarding the dyspepsia scoring system. What about gallbladder and biliary diseases? Plenty of literature about the prevalence of cholecystitis and cholecystitis. There is debate about if it represent the normal risk as non-renal population or not. Sometimes this may be common by ductal dilatation with renal failure, especially in adult dominant polycystic kidney disease. Enhanced risk of biliary infection may be accompanying these people. Laparoscopic cholecystectomy appears to have similar outcome and complications rate compared with patients without renal failure. What about the incidence? Biliary dialysis is about 33.3%, with prevalence higher than found in a non-renal failure population. This is in a senior population. A paper showed the incidence. We found that there is higher incidence for CRF group 20, normal population 11.5, CRF group 22%, and hemodialysis group 33.3%. What about the increased frequency of gallbladder stone and related parameters in hemodialysis patients? Another study showed that usually there is increase in gallbladder stones and cholecystitis in that patient, especially with repeated blood transfusion patients. Also, this another study showed that hemodialysis patients has altered bile composition rather than normal population. What about pancreatitis? The incidence is unclear. It may represent 6.4%, usually in peritoneal dialysis, higher than hemodialysis patients. Higher prevalence in peritoneal dialysis, of course, because of higher solute concentrations and other causes related to the solute itself and the dialysate itself. Risk factors such as vascular disease, polycystic kidneys, and drug ingestion and hyperparathyroidism may be adding factor. But against that hemodialysis patients would usually have higher triglycerides level, expected to precipitate pancreatitis, but this never happened because usually we are in need for higher level of triglycerides, more than 1,000 milligram per deciliter. When we have pancreatitis, sometimes it is very difficult in peritoneal dialysis patient to differentiate between it and peritonitis due to presentation is similar to those with microbial peritonitis. Effluent dialysate, amylase concentration more than 100 units per liter, appearance of the effluent dialysate, hyperlipidemia and the hypercalcemia, treated peritonitis fails to resolve after 2 weeks of therapy, radiographic imaging. These 6 items, if I have found, I should be highly suspicious that this is not simply peritonitis, this is really pancreatitis. This is a very important study which has done about 100,000 patients, including 2,603 people on hemodialysis, and they have found that hemodialysis group have higher risk of pancreatitis and biliary disease. All these papers show the same, that we have higher incidence of pancreatitis in hemodialysis and peritoneal ablations. I will not discuss hepatitis, but hepatitis B virus is regressing because of the several measures which have been taken, while hepatitis C virus still represents significant morbidity and mortality. What about lower GIT diseases? We have uremic colitis, ischemic bowel disease, spontaneous colonic perforation, fecal impaction, diverticular disease, and angiodysplasia. Usually, in these patients, we found that as we are advancing in chronic kidney disease and hemodialysis patients, we have increasing higher rate of chronic lesion, reaching up to more than 40% of the case. Uremic colitis, became historical, very rare disease, not to be observed, was noticed previously in dying personnel due to delay of dialysis or under dialysis. Ischemic bowel, which means ischemic bowel or infarcted bowel, usually may present asymptomatic or abdominal pain, fever, leukocytosis. Right-sided lesions are more severe outcome, more common in dialysis patients. Peritoneal dialysis may mimic those of peritonitis. Very difficult to differentiate. Of course, we have recorded mesenteric ischemia in hemodialysis patients, and they have found that mesenteric ischemia has lesser survival rate, of course, than patients without renal affection. These are figures that demonstrate that we have in these patients ischemic pneumosis with hemorrhage. What about spontaneous colonic perforation? It has several causes such as aluminum-containing antacids, barium studies, fecal impaction, dehydration, and higher mortality when compared with patients with normal renal functions. Chronic necrosis may be, soap-street may be responsible for chronic necrosis, take care. Steroids also may be responsible for the increase if patients have vasculitis or other neurological disease, may have an adding factor for this perforation. Signs and symptoms.
Can go for conclusion, please? Can you go kindly for conclusion?
Okay, I have
2 minutes.
We cannot have speak about fecal infection. Angiodysplasia. This cause mustn't be missed in patients with GIT hemorrhage. It represents 30% among older patients. Diverticular diseases usually also are very common in patients with renal failure on regular hemodialysis. A history of dialysis mustn't be missed in patients who are going to have renal replacement therapy, because later on they may develop after renal transplantation perforated viscus, and perforation usually has higher mortality rate, about 60%. Dialysis-related amyloidosis decreased motility with cecal perforation and usually histological examination extensive amyloid deposits. Sometimes they may associate with chronic dilatation. Idiopathic dialysis ascites, this is the diagnosis of exclusion, usually due to chronic volume overload, changing the permeability of the peritoneal membrane, impaired lymphatic peritoneal resorption, and hyperemia and congestive heart failure and hyperparathyroidism. Prognosis, of course, very poor. 45% die within 15 months. This is the diagnosis about the characteristic of acidic fluid, and laparoscopic examination should be done to exclude other causes, and treatment sought include restriction, aggressive fluid removal, malfiltration, intermittent paracentesis, nutritional intake, CAPD, peritoneal ligin shunt, Diniver or ligin shunt, and renal transplantation with a definitive treatment. GIT bleeding must be, of course, very suspicious if we haven't responding anemia for EPO treatment or iron treatment, and we should think about all causes of death. As you can see, also we have irritable bowel syndrome is increased in patients with CRF or regular hemodialysis. Take home message. Last slide, please. Take home message. GIT disorders are commonly due to dialysis patients. Frequent problems peptic ulcer disease, gallbladder and biliary disease, pancreatitis, diverticular disease, and angiodysplasia. Peptic ulcer disease is the most common cause of upper GIT bleeding. Gastroparesis may be associated with uremia and usually resolves after renal replacement therapy. Pancreatitis may occur more commonly among patients on peritoneal dialysis. The diagnosis of pancreatitis in renal failure patients is difficult. Lower GIT disorders of importance in dialysis patients include uremic colitis, ischemic bowel disease, spontaneous colonic perforation, fecal impaction, diverticular disease, and angiodysplasia. Idiopathic dialysis ascites is a diagnosis of exclusion, and thank you.
For lack of time, we postpone the questions
and answers. The next speaker ضيف العزيز الاستاذ الدكتور محمد حلاوه استاذ الاندوكرينولوجي في عين شمس هيكلمنا عن الثايرويد ديسفانكشن in CKD and hemodialysis.